heart normal. So we make the life of the patient better by doing some procedures. So these procedures are called Glenn surgery and Fontan surgery. In Glenn surgery, actually, we take the blood from the upper limbs and we connect it to the pulmonary artery, which is usually done between 6 months to 2 years, while the Fontan surgery is done 1 to 2 years later, in which we take the blood supply from the lower limbs and then connect it directly to the lungs. So why do we do all this? We do this to bypass the heart, rest the heart. So we take blood from the SVC and IVC, connect it directly to the heart, thereby preventing this blood from going into the heart, getting pumped and coming again into the lungs. In this way, we are resting the heart, decreasing the load to the heart, thereby making the heart pump more efficiently. So these are the palliative surgeries which I have mentioned, Glenn and Fontan. Glenn is usually done by 6 months, while Fontan surgery is usually done by 3 to 4 years. So again, the first transcatheter PDA closure was done by Dr. Postman in 1967. The first balloon atrial septostomy was in 1968. The history of interventions actually started only here. This was the first transcatheter intervention. Then things grew. By 1976, we had more devices, so atrial septal defects were closed. And then the evolution of devices came. Amplatzer was the first company to produce dedicated devices to close atrial septal defects. So what has happened in the last decade in pediatric cardiology? How it has grown? Slowly, many conditions are being treated by intervention. So why intervention? Imagine a child who has an AST. The norm before 20 years was always surgery. You admit the child, you do an open heart surgery in this child, and the child stays in ICU for almost 5 to 6 days. So the total duration of stay is almost 7 days. Whereas in transcatheter intervention, you admit the child today, tomorrow the child undergoes an AST device closure, the very next day child gets discharged. There is no bypass, there is no scar. So that is what intervention has brought into the field of pediatric cardiology by doing devices and many more things which I will discuss. So what are the interventions we are going to talk? Device closures, palliations by transcatheter method, valve implantation, hybrid approaches, and lastly, some few words on fetal interventions and biodegradable stents and devices. Okay. So 1948 was the first time PDA was treated in a baby, and this was by open heart surgery. But today, none of the PDAs have to be treated by surgery. Almost every PDA can be closed by means of a device. So by device, what I mean, we take access in the groin, either in the femoral vein or femoral artery. Okay. Not seen actually. Okay. So PDA surgical ligation was first started in 1948. Transcatheter closure came into play in 1967. ADO was the first device which was FDA approved, which came in 1998. Since then, every PDA was closed only by a device, and surgery was rarely the treatment of choice in PDAs. Currently, our challenge is to close PDAs in very small infants. Now let me show some examples which we have done. This is a 800 grammer baby, preterm baby. I'll just introduce you to echocardiography a little bit. So this is the blue color. In echo, blue color is away from the probe and red is towards the probe. So when we have a blue color, so probe is actually here. So when we have blue color, the blood is moving away. You can see it splitting into two. So this is the right pulmonary artery and this is the left pulmonary artery. This red flow is called as the PDA. So PDA starts from the aorta and goes into the pulmonary artery. Now this PDA should normally close when the baby is born, usually by at least by maximum 1 to 2 weeks. If it doesn't close, what happens to the baby? There is a lot of problems like bronchopulmonary dysplasia, lung infection, NEC, necrotizing enterocolitis, so many issues. So this has to be closed. So how do we close it? We close it with a device. This device is called as the PDA device. We come from the IVC, right atrium, right ventricle, and through this pulmonary artery, we enter into the PDA and we come into the aorta. And this device is deployed from the aorta across the PDA to close the PDA completely. So this is the post-procedure echo, where you can see that red flow has completely gone. So this is called as PDA device closure. The latest intervention in this field is we are able to close these PDAs even in 800 gram babies, hardly a kilo. So we have many more devices which are coming into play, and as low as 800 grams and as large as 3 centimeter PDAs can be closed easily with devices. So these are some of the various devices we have to close the PDA. We call them by various fancy names, which are called as Piccolo, ADO2 and all that. And you can imagine the size of this device. It is just less than the size of a coin. So it's almost having a retention disc of 4 to 6 mm with a length of just 2 mm. And we take this through special tubes. We cross the PDA and we close the PDA using these specialized devices. So just a small video of how we do it in cath lab. So this is a wire, and through the wire we have gone from the IVC into the right atrium, and from the right ventricle the wire is trying to enter into the pulmonary artery. So as I said earlier, we go from RA into the right ventricle and we cross the PDA, and through the PDA, and that is the wire which is entering into the PDA right into the descending aorta. So once we have entered the descending aorta, we bring, that is the aorta filling in this injection, and once we have entered the aorta, we bring the device using special sheets, and these sheets are helped to deploy the devices across the PDA accurately. So this is about PDA device closures. So the thing I want you to remember is PDA is not amenable only to surgery. Surgery is not the rule to close PDAs. Now the technology has grown where we can close PDAs even in very small babies, starting from 800 grams up to even an adult male or female who has a large PDA of even 3 centimeters. So that is one take-home message from this. The second defect which I want to discuss is AST. Now coming to AST, these are septal defects which are present between right atrium and left atrium. The types of ASTs are sinus venosus AST, foramen ovale, septum secundum AST, coronary sinus AST and primum AST. Except this primum AST, every other ASTs can be closed with devices. So this is how in echo it appears. So this is the atrium, and between the two atrium you can see the interatrial septum, and this red flow is the septal defect. Now we close the septal defects by using special devices which are called as AST devices. Here this patient has 2 atrial septal defect, and both of them are closed simultaneously by using 2 AST devices. So this is again an innovative procedure which has come inside, where we can even close multiple defects in a single procedure, which hardly takes 20 to 30 minutes. Now the same patient post device deployment. Now you are seeing the atrial septal occluders attached to the atrial septum, and completely they have closed that red flow. That is the hole which we saw earlier in the echo. So multiple AST device closures, large ASTs, everything can be closed by transcatheter methods. And this is a special type of AST, sinus venosus, where we don't use a device to close, where we use special stents. These special stents actually redirect the blood flow from pulmonary vein into the left atrium. What happens in sinus venosus AST is the pulmonary venous blood, rather than entering the left atrium, they enter the right atrium. So this has to be prevented by using special stents which have covering around them. So when we deploy these stents across the SVC, as shown in that picture, the pulmonary vein blood is entering LA directly rather than entering the right atrium. So in this way, we have closed the sinus venosus AST defect. So this procedure is called as stent exclusion of sinus venosus AST. So this procedure helps us to close these type of AST defects which cannot be closed by devices which I mentioned earlier. And then, so nearly 90% up to 95% of ASTs can be device closed. We can do it even in less than 5 kilo baby, and rarely in the first year. Usually we close ASTs by 3 to 5 years. Initially it was 5 years, but now with the advances in technology, we can even close at 3 years. And sinus venous CST, we usually wait up to 10 years to close because we need special stents to close these ASTs. Coming to VSTs. So what are the types of VST? We have perimembranous VST, inlet VST, muscular VST, and doubly committed VST. So every VSTs, these are all multiple angio pictures which are showing that which are showing the VSTs in different position. What I want to convey is almost every VST is amenable to device closure. So we have special devices, array of devices, which are all having two discs, one disc on the LV side and one disc on the RV side, a special waist in the middle to occlude the septal defect, and thereby causing complete occlusion of VSTs. So be it doubly committed, perimembranous, mid-apical or outflow muscular VSTs, all these VSTs can be closed within a matter of 30 minutes using specialized devices. So any sort of VSTs, any weight of the baby, they are all amenable for VST device closure. So these are all angiograms. I'll just explain one angiogram for you to understand. So this is the heart. You are seeing the left atrium here, the left ventricle here, the right ventricle here, and the right atrium above. So between the left ventricle and right ventricle, you can see the dye passing by. This is the ventricular septal defect. We have closed this ventricular septal defect using this device. So it is completely occluded without any surgical procedure. Again, we have done this procedure in hybrid way, where the surgeons come to our rescue. We open the right ventricle in OT, introduce the sheath across the septal defect, and then we deploy the devices with the help of the surgical team. These are all small babies with very large holes, which may not take the bigger tubes we need to deploy these devices. So we take the help of surgeons. In OT, we ask them to open the right ventricle, and through that hole, we take the sheath, cross the VST, deploy the device, and come outside. In this way, we save time, we avoid the child going into cardiopulmonary bypass, and the ill effects of cardiopulmonary bypass are prevented. So just to a recap of about the different VSTs. Perimembranous VSTs, if symptomatic, less than 6 months, surgery is the main mode of treatment. More than 6 months, surgery or device. Muscular VSTs, less than 5 kg, either surgery or hybrid procedure. More than 5 kilo, it's for device. Doubly committed VSTs, less than 6 months, surgery. More than 6 months, more than 6 millimeter, surgery. More than 6 months and less than 6 millimeter, they can go for a device closure. And we have different types of balloons now, starting from almost 8 mm up to 100, 200 millimeters, which we use in different procedures like coarctation of aorta. So what is the treatment of coarctation of aorta? Either surgery or intervention. 1 to 6 years, the current guidelines recommend balloon dilatation, while stenting for more than 7 years and more than 35 kg. So here we can see a significant coarctation in this child, which was relieved by means of stenting. So these are the special covered stents over the balloon we use to expand and to relieve this coarctation site. So some examples for you to understand. So here we have gone through the IVC, RA, RV, through a VST into the left ventricle, and we have come through the aorta into the coarctation, and we are deploying the stent across the coarctation. This is one more way to treat coarctation. Or we can directly come from the aorta, cross the VST, and then deploy the stent across the coarctation site. So these are all some pictures which are actually showing the stent across the coarctation site, nicely ballooned out and treated the coarctation. Again, coarctation can be existing with multiple other diseases like PDA. They can have multiple comorbidities. So we can treat also multiple conditions. See, this is a condition where there is a coarctation and there is a PDA. So we have closed the PDA and we have stented out the coarctation in the same aspect, in the same sitting. So such multiple procedures are also possible. Coarctation stenting with PDA device closure. So and again, this is an interesting case where we have this condition is called as coronary cameral fistula. So what are they? They are special tubes which actually come by nature from the coronary artery into the atria, causing volume overload in the atria and ventricle. So we come from the aorta, go through the coronaries, enter these coronary cameral fistulas, and we have deployed a device into that tube. That is the coronary cameral fistula tube, and we have completely occluded the coronary cameral fistula. Again, this is something which is very much possible through intervention. This is a post-surgical patient who had an aortic surgery and developed a huge ascending aortic aneurysm, which we have actually closed. Now, this is a pigtail catheter, which is there in the aorta, and this is the defect. This is the ascending aortic aneurysmal defect, which we have closed with a huge AST device. So again, what are the possibilities? Because this patient has to undergo a redo surgery, multiple redos, increased morbidity and mortality, but we have successfully treated this with a device. This is a new technology which is coming up, which is called as fusion technology. In this, we can actually fuse the CT imaging with the catheterization imaging. Again, this is a submitral aneurysm, which we have closed with a device using the Philips navigation technology, where we have fused CT and angio imaging to understand where the defect is exactly, and we have closed this with a device. Coming to the palliation. So, as I said, so far we have discussed curative procedures, be it coarctation, septal defect, or AST, VST, PDA, they are all curative. The second category of diseases is called as palliative surgery. So here we make the child life better by doing some procedures like ductal stenting, RVOT stenting, which is done to increase the pulmonary blood flow. So these are the children who are tetralogy of Fallot, who are born with severe PS, and we do these procedures to increase the pulmonary artery blood flow. We also have some procedures like PA banding through transcatheter method to decrease the pulmonary blood flow. So a child might be born with decreased pulmonary blood flow or increased pulmonary blood flow. For decreased pulmonary blood flow, we use procedures like this, RVOT stenting and ductal stenting. For increased pulmonary blood flow, we use the procedure called as PA banding through transcatheter method. So this is an example of tetralogy of Fallot with severe PS. So we have gone from the IVC into the RA, into the RV, and we have deployed the stent across the right ventricular outflow tract to open up the RVOT, thereby increasing the blood flow. This is a life-saving procedure. These children are usually born with severe cyanosis with saturations of 30 or 40%. Post-procedure, their saturations increase dramatically to 70-80% within minutes. So again, a life-saving procedure in the transcatheter field. So we also have a procedure called as ductal stenting. Same way, when there is pulmonary atresia, the pulmonary arteries are actually supplied by duct coming from the aorta. We can go through catheters into the aorta, we can cross this duct, and we can stent these ducts out. Just like RVOT stenting, these ductal stenting also improve the pulmonary blood flow, thereby saving the life of the child by increasing its saturations. Now, this is the new thing which is coming up in interventional cardiology, which is called as transcatheter fontan. So at the beginning of the lecture, I explained what is fontan. So can we do this fontan by transcatheter method is the first, is a new thing. So what is fontan? We take the IVC blood and we direct it into the pulmonary arteries. Initially, the first surgery for this child would have been a Glenn, where the SVC is connected to the pulmonary arteries. The second surgery is called as fontan, where the IVC is directed to the pulmonary arteries. At the beginning stage, this procedure was actually done. When Glenn is done, a conduit is stitched between the pulmonary artery and the IVC, and then it was stented. But nowadays, we have started doing this procedure without a surgical preparation. That is, in all children who have underwent Glenn, we have done this transcatheter fontan procedure. So how do we do it? We come from above through the SVC, we puncture into the atria, we cross the wire through the wire into the IVC, and then we put a long covered stent from the pulmonary artery into the IVC. In this way, we are directing the blood from the IVC into the pulmonary artery. So this is the new kid in the block in interventional cardiology, which is called as transcatheter fontan, where we can actually direct the blood from the IVC into the pulmonary arteries directly. We use technologies like 3D printing for this. So this is a 3D printed model of the actual heart of a child using resin. So you can see the pulmonary arteries above, the SVC, the atria, the IVC, all that which helps us understand the anatomy of this congenital heart disease and plan the transcatheter fountain. So I'll show some angios. Again, this is the navigator technology. This is the SVC, the branch PA, and the atria. This is where we puncture from the SVC into the atria and come into the IVC, and we put a stent from IVC into the pulmonary arteries to redirect blood from the IVC into the pulmonary arteries, which is basically the fountain surgery. So the stent is going from IVC into the pulmonary arteries, and you can see the dye which is reaching from the IVC into the pulmonary arteries. So without surgery, transcatheter fountain is also a possibility now. That's what I wanted to convey. And the other procedures, we can do this transcatheter in multiple substrates like disconnected hepatic veins, single lung fountains, and so many other conditions where we have actually done these transcatheter fountain with pulmonary artery stenosis, without pulmonary artery stenosis. So multiple substrates where actually transcatheter fountain is a possibility. And they have done very well in follow-ups. So this is the first. So as I explained, the SVC is connected to the pulmonary arteries. We have punctured from above. We have put a wire into the IVC, and then we have put a stent which redirects the IVC blood directly into the pulmonary arteries. So this completes the fountain surgery without fountain procedure without surgery. So other than that, as I mentioned earlier, to decrease the pulmonary blood flow, we do a procedure called as PA banding. So we go from IVC into the PA, and we deploy special devices like this into the pulmonary artery, which actually decreases the pulmonary blood flow. So in cases like TOF with no PS, DORV, double outlet right ventricle with no PS, we have to control the blood flow before Glenn surgery. As I said, Glenn surgery is usually done by 6 months to 1 year. Till that time, if blood flow is more to the lungs, we have to control it. The only way is surgery. We do a surgery called PA band. But that PA band can be done now with intervention like this, deploying 2 devices in either branch PAs with holes in the center, thereby decreasing the effective blood flow to the lungs. This is called as transcatheter PA band. Again, we have conditions like severe pulmonary hypertension, where we cannot close the holes like septal defects directly because the pressures in the lungs are very high. So we convert a bigger hole, that is the AST, into a smaller hole using devices like this. This is called as AFR, which is atrial flow regulator. So what do we have here? We have a large septal defect here. We have deployed a device across the septal defect, which has a small hole of 8 to 10 millimeter. So we have converted a 20 millimeter hole into a 8 millimeter hole. We have decreased the blood supply to the lungs. At the same time, we have decreased the shunt to the lungs, but we have not closed it completely. So when the pressures in the lungs increases, this will be like a pop-off for the right ventricle to prevent right ventricular failure. This procedure is called as atrial flow regulator or an AFR procedure. Again, this is the latest innovation in pediatric cardiology, where we have used these devices in multiple conditions like high pulmonary artery pressures, left ventricular failures and all that, to prevent left ventricle and right ventricle failures. So apart from this, we also have transcatheter valve implantations, where actually we can deploy through special sheets valves like this across the pulmonary area without surgery. We have various sizes of valves starting from almost 20-25 millimeter up to 35 millimeter. Without surgery, we can treat pulmonary regurgitation, pulmonary stenosis, aortic stenosis, and aortic regurgitation. So these are the transcatheter. So today, majority of conditions in pediatric cardiology can be treated without surgery, be it curative or be it palliative. All these conditions have come under the gamut of interventional pediatric cardiology, and that's how it has grown over the last decade. A few words on fetal intervention. So when the baby is inside the mother's womb, we can actually do some interventions like aortic stenosis relieving by balloon aortic valvuloplasty. Using ultrasound, we take a needle from the mother's abdomen into the child's heart. We take special catheters which enters the aortic valve, and we can balloon dilate the aortic valve in utero. In this way, we prevent the LV from going into failure or regressing. We allow the LV to grow and thereby relieving the aortic stenosis. This is called intrauterine balloon aortic valvuloplasty. And the latest advances is we have stents and devices which are biodegradable. You deploy these stents, this is AST device. You deploy this AST device in a child to close the atrial septal defect. Within 6 months, the device actually dissolves in blood. They are made of special polymers, and there is no evidence. There is endothelialization, growth of endothelium above these devices, and within 6 months, the entire stent or the device architecture dissolves, thereby curing the condition without leaving any residuals. These are called biodegradable stents and devices. So these are some examples of the same, where we use these sort of devices which are completely dissolvable in blood. So in summary, there are many conditions which were deemed for surgery in the last 10 years ago, but today with the incredible advances in intervention, we can treat most of the pediatric cardiology condition with intervention. So that's the main thing I wanted to convey. Thank you.
Thank you, sir. Very extensive experience, and it is actually very astonishing. You are doing everything interventional. And initially you told the classification of congenital heart disease, structural atherosis, major, complex, and simple. It's no more cyanotic, no acyanotic.
No, this is just for this talk I have classified like that, but it is still acyanotic and cyanotic.
For students' purpose, cyanotic,
cyanotic, acyanotic.
So from your point of view, it is major.
Correct. From the talk point of view, I wanted to say which are more complex for intervention, which are more simpler for intervention. That's why I have classified in that way. But as per textbooks, congenital heart disease are always classified as cyanotic and acyanotic.
Any queries from audience?
So for the students, I just wanted to convey one thing. Surgery is not the only option for septal defects, be it AST, VST, or PDA. So whenever you are seeing AST, VST, PDA, remember that child can be completely cured for life by using such advanced device closures which is possible within a day. So when you have someone you know or some relative who needs AST, VST, or PDA device closure, please feel free to contact us, because we have the technology to close these defects without surgery or without a cardiopulmonary bypass, which will immensely help the child in long run. Thank you.
Sir, one question. Nice detailed explanation, sir. Fetal intervention, which cardiac defect can be easily treated?
Correct.
Fetal intervention, by doing fetal intervention.
No, as of now we have done only for aortic stenosis.
Oh.
Then no other conditions we have treated with fetal intervention, because it's too difficult, because ideal fetal position, so many things. We have even waited for 2 days to do the intervention in a child, in a fetus, just to attain the complete position, because it has to be exactly in the cephalocaudal position for us to introduce the needle to pierce through the apex to go into the aortic valve and do a balloon aortic valvuloplasty. So as of now, the only procedure we have done is a balloon aortic valvuloplasty.
Any role of robotics?
Robotics, sir? No, we have not done robotics, sir. Intervention is not.
Thank you, sir, for embellishing our elements. Now we request the chairpersons to felicitate the speaker.
Now we request the speaker, Dr. Ram Kishore sir, to felicitate the chairpersons.
Much like a noose tightening itself around, these vessels constrict, bind, choking out our foes of life.
As the Suez Canal bridges two halves of the globe, to bypass the noose, we may look within ourselves.
In agony we lie, awaiting with wailing hearts and heaving breaths, for our surgeons to win their wands and ameliorate the madness.
With a firm grasp on our guide wire, let us delve into the depths of the topic, total arterial bypass grafting.
This session will be chaired by Dr. Karunanidhi Sir, Consultant Pediatrician, KVS Hospital, and Dr. Rajashekharan Sir, Assistant Professor of Pediatrics, Government Tiruvannamalai Medical College and Hospital.
We now call upon Mr. Vishnuvardhan to provide a prologue on the speaker of the hour.
It's my esteemed pleasure to invite and introduce Dr. Dheeraj Sir, MS, MCH in Cardiovascular Surgery and Thoracic Surgery. Sir is a top cardiac, thoracic and vascular surgeon at Apollo Hospital.
Thank you, Thambi.
Dreams Road, Chennai. Thank you, sir.
Let's start. How many people understand? Okay, I'm Dheeraj, Dr. Dheeraj, cardiothoracic surgeon from Apollo Hospitals, Chennai. Studied in Ramachandra. How many people understood the previous session? No, because he gave a very extensive talk. It was like a MCH revision course for me. Thank you. I learned a lot because 10 years back, as he said, for anything in the pediatric division, the only way to go forward is to do surgery. And it was very difficult to open 1 day to 1 year old chest to open. I found it difficult, so after I finished MCH cardiothoracic surgery, I said, no more opening baby hearts, let's go to adults. So I figured out how do we start to do the best possible way of bypass surgery. So when you start bypass surgery, okay, how common do you think is bypass surgery? See, okay, let's interact, okay? Now, I know everybody are postprandial, glucose is high, and you'll all like want to sleep. I'm not going to let you sleep. So let's interact. How common do you think bypass surgery is done? Quite common. How quite? In Chennai, there are 100 surgeries done a day. Can you believe that number? A minimum is 100, only in Chennai. In Tamil Nadu, somewhere about 500. In India, somewhere about 3,000 people are getting operated every day. So it is a very serious problem, but luckily, I compare cardiac surgery with flight journeys. The crashes are very rare, but once it crashes, that's the end. There's no survivor from any crash. This 11A stories are all nonsense. Don't believe that story. Okay? That guy went in and came out. So are you aware of this 11A seat? Konjam pesalame. Pasi theriyudu. Saaptingala? Okay. Now let's go to the topic. Okay, now when we started coronary artery bypass surgery, there are various ways to do, like various conduits to do the bypass surgery. Like when we say to the patient, to make the patient, okay, now I'm trying to come down because I cannot talk like a super specialist to a MBBS guy because you're not going to understand anything. Okay, now I'm coming to your level to make you understand what is bypass surgery and why it is done, how it is done, and how do we take things forward. Now, we compare the coronary arteries to roads. So which type of road is the best road? Cement road or tar road? Huh? You all fail. Cement roads are better. The most commonly seen roads are tar roads. Agreed? Why? Okay, everything boils down to money. No, it's easily available. It is easily, what do you say, to repair it is easy, to make it is easy, and it is cheap. Never put money first because that will be the last thing to get at the end of anything, okay? Money is always a byproduct of medicine, okay? Don't work for money. You understand? Do your work, money will follow you. This is just out of this thing. So tar roads are the most common roads. So in bypass surgery, if there is a block in what vessel, artery or vein? Fail. What artery? Appa. Okay. How many arteries are there? What? Why girls are only talking? Boys are all sleeping? None bus? Okay. There are two arteries. In that, right and left. So arteries, the first common way the bypass was done was using a vein from the leg. What vein? The boys will answer. What is the vein meant? Femoral vein, saphenous vein, sural vein? Huh? Great or short? Okay. Is there something called sural vein? Yes, sir. Okay. Now, coming to the best possible way to do bypass surgery is to use an artery. What artery? It's called left internal mammary artery, internal mammary artery. How many arteries we have? I already gave you the clues left, so there should be one more. How many are there? 2 or 3? So 2 coronary arteries, 2, sollu men. So 2 coronary arteries are there and 2 internal mammary arteries are there. One is on the right, one is on the left. So what does the internal mammary artery do? It just connects the thoracic anterior. Okay, I'm taking anatomy class now. So I've come down to first year. Okay. So the best possible, let's not go so deep. The best possible way to do bypass surgery is to use an artery because the blocked vessel is also an artery. So coronary artery to an artery. So the other arteries which can be used is the radial artery and the gastroepiploic, which is not used at all. It's just on textbook. For completion's sake, we do that. Okay, now why do we say artery has to be given an artery? Why cement roads are better than tar roads or vice versa? I told no, only Chokkalingam's this thing, everybody laughed and smiled and did everything, but now everybody is sleeping. I wantedly asked for this session after Chokkalingam. I wanted to talk because I know he's going to make the crowd laugh and have fun. I don't know how much you guys are going to carry home, but that will not bring you marks. This will bring you marks. And this will definitely help somebody on the road. So why tar roads are less, they're very common, but cement roads are very, very durable and long lasting. So coronary arteries are very, very important arteries, and the mammary artery is the only vessel which is in the same diameter of the vessel, so the patency rates are very high. Okay, that is the reason we use the what artery? Internal mammary artery. So if at the end of the class, if I ask you 4 questions and if you give those 4 questions, then I know that you guys are listening, okay? I will ask you, I'll point. This has a pointer, no? The pointer, girl? Okay. So be ready, guys. Okay, now saphenous vein is the most common used conduit. Why? Because it's very easily accessible. They take it, and whether in case of emergency or anything, there is a separate team working in the leg end. They operate, they take the vein before even the chest is open, and once the chest is open, they go and do the bypass, put the saphenous vein on the LAD or the left anterior descending artery, circumflex or the right coronary artery. Now radial artery is also used, but not very common. But the most common is the saphenous vein. Now why do people call me as a young surgeon who's doing good work and stuff is because I use only the mammary arteries and I don't use anything else in my practice. If at all I cut the patient, it will be only one scar in the chest and no other scars in the body. No leg scars, nothing. How many people have parties and tatas at home with bypass surgery done? Okay, so hardly, very few. I'm happy that we are living in a healthy community. Okay, why the internal mammary artery is the most important, and the reason why it is the best conduit is this. This slide, it took so many years of practice to understand why it is the best. And there's so much of R&D done in this. If you guys can take home this message and help or guide anybody in your practice tomorrow, the best way to do bypass surgery is use the mammary arteries. Today's talk is successful. So why we use it? It is rich in this. We are going to medicine now. Enough of theory, okay? Let's go deeper. Rich in intrinsic nitric oxide. So what does nitric oxide do? Very good. Resistant to atherosclerosis. What are the other things resistant to atherosclerosis? Dr. Chockalingam said. Tellman. Chockalingam also told about atherosclerosis prevention, no? What? Huh? We'll go to that also. It is a less muscular artery than radial artery. That is the reason radial artery went out of vogue. Radial artery is used, but less, because there is the muscular layer in the radial artery is thicker, so the chance of spasm is very high. That is the reason we stopped using radial artery like how we use the mammary artery. It is thin-walled and less dependent on the vasovasorum for this vasospasm. And after doing surgery, there are patients whom you see changes in the ECGs. The first reason they say, if there is a change in the ECG, the mammary artery is blocked. Usually it is secondary to spasm of the mammary artery because of not harvesting it properly. It's a technical fault, technical error. Good reactive to vasodilators and less reactive to vasoconstrictors. And as I said, artery to artery is the best way to do the bypass surgery. Arterial conduits have best patency, this I already told. Okay. I'm just going because it's all Greek. Okay, this is the way, will this play? It's a video. So, no, there's no video, there's no sound there. Take a video. No, sound illanga. Is this working? It's not seen there. Okay, what you see on the top is what artery? Enna man, yarume pesa maatendreenga. There are only two arteries, no? Internal. Edhum mudiyalana internal mammary artery appdinu sonna podum. Adum solla maatendreenga. That is what you see on top is the left, what you see on the down is the right. Okay. Can you play this? Okay, that is the heart, which after bypass surgery is done, where we have done 6 grafts to the heart with using 2 arteries. Illa. Sir, our varthukula talk mudichunu, sir. Sir. Ungala dhaan sir paakranga, enna paaka maatanga. Puriyudhu sir, ukkarunga sir. Paravala sir, no problem. Na pesikren. So we have done 6 grafts here. Now this patient has only 2 coronary arteries and we have done 6 grafts. So how does it make any sense? Yes, no, all right. Makes sense? How? 2 coronary arteries, right and left sonninga, but I've done 6 grafts. Why? Huh? Good. So what are the branches of the LAD? Whoever answers will get 1,000 rupees. Going the Chokkas way. Huh? No, I'll give 1,000 rupees, definitely. GPay on the spot. What are the branches of the LAD? Huh? You have to be, see, you want 1,000 rupees, I have to pay you, no? So, solely I said, sir, I will take care. So what are the branches of the LAD called? Diagonals. So whoever said diagonal will get 1,000 rupees. Whoever wants to claim 1,000 rupees, come and get it and go, okay? What are the branches of the circumflex called? Okay, what marginals? Obtuse or acute marginals? It's called OMs, okay, obtuse marginals, that's all. If you understand, so the branches from the LAD is called diagonals. The branches from the circumflex is called marginals. And what are the branches of the right coronary artery called? Has no branches at all. Sollangappa. No, it divides into two. The right coronary artery divides into posterolateral branch and posterior descending artery. When there is an anterior ascending artery, there is a posterior descending artery. It's called, which is a branch of the right. So now you have two diagonals, two marginals, and an LAD. How many are there? 5. 2 diagonals, 2 marginals, 1 LAD, and 1 PDA. How many are there? So we got this thing. So if there is a triple vessel disease patient, that means any patient who has block in one vessel is called single vessel, both the vessels is called double vessel, and all 3 vessels, that is both the right and the left. So LAD and circumflex is called double vessel disease, and if all the 3 systems are involved, it is called triple vessel disease. So any patient with triple vessel disease will require somewhere up to from 3 to 5 grafts or 6 grafts, depending on whether the origin of the diagonals, origin of the marginals, and the PDA have disease. If they have disease, they have to be grafted separately. Understood? Okay? That is the reason we did 6 grafts in this patient. A cardiac surgeon will understand how important the 6 grafts are. I'm trying to make you understand, okay? If you don't understand, I'm sorry about that. This is one more case with 5 grafts. Done Rima Lima Y. This is the Y. LAD. Diagonal. OM1. This is the small OM, but this 1 mm we didn't do. OM, last OM. And PDA. Okay? Now, okay. The other doubt after we do this, the next slide which I am going to show is, can you just pause this for some time? No? Just pause. Now, I have done the bypass. Is the blood flowing? Is the doubt. Like, நான் படிச்சேன் ஆனால் எக்ஸாமில் பர்ஃபார்ம் பண்ண முடியல ஒரு பயம் இருக்கும்ல அந்த மாதிரி. You have to keep checking yourself because if you do the surgery and if the grafts are not flowing, you have nothing less than a dead patient. Patient dies. Okay? So, we need to check our flows, the techniques of anastomosis, and we do it in such a level of precision where there is, the chance of failure is less than 1%. The mortality, what do you think the mortality of cardiac surgery is? Oh, wow. So for every 105 you will accept. Sorry, sir. The accepted mortality worldwide is 1% and less than 1%. Depending on the center, expertise, equipment, because there's a lot of improvisation in the equipment. Today, any patient who comes with severe cardiogenic shock, you can put them on IABP. What is IABP called? Intra-aortic balloon pump. That is a device which protects the heart in a cardiogenic shock, okay, to save a patient. For common people, like how CPR they do from outside, this does from inside. By giving the blood back from the aorta, whatever comes back from the heart, the balloon pump from the aorta will give it back. So the coronary perfusion increases. Okay? The reason why I wanted to show this video is, okay, we have done the surgery, is our grafts flowing, is the doubt. So what I do on table as a routine is, after doing the surgery, the last graft I open to show what is the flow. That will tell us, This is an indirect way, the proof that I'm standing here and talking is me voicing. You can hear my voice like that. You can see the flow there. Play the video, no?
We just want to see.
So that, after doing the last graft, the fifth graft,
this is the flow.
That's the flow what you see on the coronary artery. Can you see the flow? Yes. Can you see the flow? Hey, yes or no, solradhukku Maya? Okay, now what is the normal BP? Huh? What? Systolic is how much? 120. Diastolic is? Okay, one more very important, this is a suggestion, okay? Never tell one number in medicine, okay? Never, because, never tell in anything, if hemoglobin, other than the value of a patient during rounds, if you go and the doctor, the chief doctor asks, you tell the hemoglobin is 7.6 or 8.6 or whatever. But till you finish your practice, don't tell any value or don't tell any mnemonic to the examiner. Keep the mnemonic in your mind. Mnemonics are important, values are important, and always tell range. So what is the systolic range? 100 to 120. Okay. After BP class, if you know this, is happy. What is the diastolic range? What BP do you see there? So is that good flow or not? No. See, this is, okay, good. Now, what you said is right. Patient's pressure is 90/50, okay? At 90/50, now can you play the video again?
We just want to see after protomin how is the flow in the last graft. This is the flow.
For that pressure 90/50,
So the pressure also.
that is very good flow. You understand? So now how we are checking the flow is, in the BP liye ivla nalla flow irukku. Yaara bell adichadhu? In the BP liye the flow is good. As the BP increases, it will get better. That's all. Okay, this is an indirect way to tell. Understood? Okay, this is a scar. You'll have one single scar in the midline of the chest where we cut open the sternum. What are the parts of the sternum, boy? 1,000 rupees question. No? Okay. So we cut open, and these three holes down are for the drains. We put one in the left pleura, one in the right pleura, and one in the retrosternal, just behind the sternum, okay? This is one young guy who wanted, he had only one vessel, single vessel. So I did a minimally invasive heart surgery where we took down the left internal mammary and put it on the left, which artery? Left anterior descending artery, LAD, okay? So Lima to LAD is a standard operation done by 90% of the cardiac surgeons. The other vessels getting the arterial grafts is what matters, okay? So this is called minimally invasive cardiac surgery, so-called now robotic surgery. This is the achievement at this point in cardiac surgery. Soon I'm planning to do cardiac surgery Lima to LAD through that hole what you see there. The down you see a black dot, no? That will be achieved shortly. We are working on it. Not as easy as we can tell, but can be done. If I start it, one of you guys here will complete it tomorrow. Are you guys willing to do that? How many people want to become cardiac surgeons? Okay, 1, 2, 3. Okay. Okay, after this talk, a few more will join. We'll see. Okay, now why do people don't do this is other than the tar road and cement road story? Why do people don't do, why do cardiac surgeons don't do this is they give a lot of excuses like obesity, diabetes, infection, this, that. But if you want to do something in life, there is only one way about it, is to just do it. If you don't want to do something, you have 100 reasons to say no. Yes, no. Sollangappa. So whoever wants to become a cardiac surgeon, think about doing only total arterial, okay? Now there is, in our unit, there is less than 1% of wound infection, which is in common with any other cardiac surgery. So wound infection should not be claimed to say because of wound infection I am not doing. There were like 15 to 20 years back, there were patients with Hanuman chest. You know what Hanuman chest means? A sternum opened, totally necrosed because of wound infection, pus. So the entire sternum here will be gone. So what they'll do is they'll raise the pectoral muscle on both sides and make a pectoral flap and close it. So in this center part, there'll be no bone at all. That was the reason of wound infection on bilateral mammaries 20 years back. But we have evolved from wound infection, and today we have brought the wound infection level to less than 1%. Okay? And the one more important reason why we don't want to do other than arterial grafts is we don't touch the aorta, because one end goes to of the saphenous vein goes to, or the radial artery goes to the diagonal or OM or PDA, the other end goes on the aorta. That's the reason we don't. Okay, this is too complex. When will you say a patient has got LV dysfunction? So for that you should know what is ejection fraction. Less than? Huh? ஏதோ ஒரு நம்பர் கேட்குறேன். Okay, 40, 50, 60. 40 கை தூக்குங்க, 50 கை தூக்குங்க, எல்லாத்துக்கும் கை தூக்குறீங்க. 60க்கு? Okay, anything less than, okay, broadly in day-to-day practice, anything less than 50% is called LV dysfunction. Anything less than 35% is severe LV dysfunction. Anything more than 50% is normal LVs. So they will not cause any problem in the post-op period. They will just sail away. Like you just start there, it goes off. Okay? So can it be done for severe LV dysfunction? Yes, we have done it. And okay, this and all is too much. Okay, coming to the analysis where what is the difference of traditional bypass surgery where they got one artery and a few veins and all arteries, is there any difference in the post-op period? How many days each patient stays in the ICU? How many days they stay in the ward and when they get discharged? In our unit, they are better than the units where our average length of hospital stay was day 4 they get discharged. Say Monday you do the surgery, Tuesday, Monday, Tuesday he'll be in the ICU, Wednesday he'll come to the ward, and Thursday he'll be discharged after doing bypass surgery. Okay? So there was no difference when we compared ourselves with the other units who were doing the other types of surgery. This is too much. Okay, in conclusion, whether it can be done for all patients, yes, it should be done. If you fail not to do it, learn how to do it. But this thing has to be it. Try to do the coronary arteries with mammary arteries. That's all. Thank you. Okay, now coming later. Thank you. Thank you, Sonona. Okay. Okay, now coming to, now this is all theory. like how we take life after the disease comes. As doctors, we have to think about preventive healthcare. So now how do we take life on preventive healthcare is, you need to do basics like how Dr. Chakkalingam said that these are the things to do. Can people enumerate what and all are the things on preventive healthcare? These are all these things, sir. I'm not, that is standard. No smoking, no alcohol. But remember the mnemonic called wafers, okay? This is just a mnemonic so that you can, in your day-to-day practice, you can talk to your patients. You don't forget to miss a point on this thing. First is water. Like you need to, for metabolism, you need how many liters of water a day? Volume overload status. An average person should drink 2.5 to 3.5 liters. So now, a severe LV dysfunction, you ask them to drink 2.5 liters, he'll come to the ICU the same night. Okay? So water, 2.5 liters per day. So once you drink water, what will come? Urine will come. So how often you should empty? This is, I'm being very serious on this. This is very simple, but yet ignored every day. So how often do you think anybody should use the restroom? I'm talking, this is not about anything or not on cardiac health. I'm talking on general well-being. Every 4 hours. So water is sorted. Next is, what is the next word in wafers? What is air for? What does air do? So consciously breathe. So what is conscious breathing called? So I don't want to be the part of the Aryan or Dravidian part, the humanity part. You need to breathe consciously. Do a format of yoga or some format where you run, where you breathe more, or consciously breathe. What is the next? That's called pranayama. Yeah, good, thank you. What is the next called? Next, this thing. What is F for? Food. Actually, it's fruits. Fruits, berries, nuts. Just add all 3 there. And that will help to take your antioxidants, omegas, all this. What is your next? What is E for? Good. Exercise. Recreation, exercise, entertainment should be a part of life every day. So, you need to exercise how long a day? What is the numbers? What does the standard recommendations are? Till you get biceps or family packs for 6 packs? Very good. So target 200 to 250 minutes per week. You will hit 150 minutes a week comfortably. So 30 minutes an average a day, 5 days a week is 150 minutes a week. What does exercise prevent from? Innada? Romba complex ah ketta. Obesity. How obesity is causing a problem? Now, in 2010, 1 in 10 were obese. You know what is the stats today? 1 in 3 are obese. So you start counting, the third person is obese. I'm sorry for pointing. Some people will get offended, but this is a fact. Now, that is one reason I'm consciously maintaining myself, so that because when I preach, I should also be in a level of preaching. You understand? Because the first time I went to a class in cardiology in my PG days, the professor who taught me was obese. So I was like, he's talking about obesity and he's obese. That is because then I thought, okay, there should be a change, and we, the youth, the next gen, should also take care of yourself. So what is the next word of the mnemonic? Rest. Sleep well. How long to sleep? That you'll all know well because Chokalingam said that very clearly. How many hours? So target 6 to 8 hours. So you can't say, everybody will want to sleep. Now you'll sleep, but after the older you go, your sleep decreases. So target 6 to 8 hours. So now, when you say sleep, there is a time to sleep also. Okay? So there is what is circadian rhythm called? Very good. Which gland does that? Where is that gland? Brain only, sir. Okay. Very good. None of these guys, all are in circadian rhythm for this thing. So, sleep is best at 11 o'clock, 11 p.m. after 10 and 5. That is the best time of... So, how sleep is important? Why do people sleep? Yeah. So now, every day, there is multiplication. I'm going very basic. You go to the histology of this. Every day, there is endothelial damage, skin, hair, cells, making the one side, there is a production of cells. What is the graveyard of the body? Good. So, doing all this is to recycle the system. So, that's how sleep is important. So what does the S stand for? The S is only for sleep, the R is for the thing. One more S is for sunlight. Expose yourself to sunlight 30 minutes a day. 50%. Now if you check everybody in this room, 95% of them will be deficient of what vitamin? Why? It gets converted there. Okay? So because of lack of sunlight, all the itching problems, hair fall, lot of reasons are there where sunlight plays a role to rejuvenate your body. Your circadian rhythm starts with the sunlight. And if just to finish the thing, S is the first thing which he said, stop smoking. So that S. So there we end this show. Thank you. Sorry if I bugged you with an anatomy class and all this thing. It's a very light session. Thank you. Now questions, please. No questions at all. You understood everything so clearly. How many valves are there in the heart?
Sir, Hello?
There are 4 valves.
Hello.
Who names the valves will get spot 1,000 rupees.
Hello.
Seriously. One come and tell me I should hear everywhere. I'm not Chokalingam, I'll pay immediately. Okay, where are those valves? Tell me. Everybody will tell. But I'll give you 1,000. He's getting the 1,000 men. Don't worry. Tell me, where does the pulmonary valve, what are the chambers which it connects? Very good. Okay. What is bicuspid valve otherwise called? Very good. Okay. One more. Okay. You come down, I'll give you 1,000 rupees. Okay? You want cash or GPay? Okay.
I took that class for him,
So because he took the class, he has to pay him. I can only pay you.
Sir, I have two questions.
Please.
One is question of concern, another one is question of conflict. Question of concern is, when you was looking for the flow of blood, when the surgery was done, you said the BP was somewhere between 86 and 47. So, was it because the pulse pressure was maintained?
No. The reason why, the pressure was low is when you lift the heart, it tends to go low. That is positional, because I lift the heart, I position it, no? Okay. In that, when we do the grafting, it is maintained at 100 or 120. But when we, for the video, like when you, so it's like when you open it and see, in the pressure level, normal pressure level, it will double. So that was only positional. It was not, that is not the pressure maintained. That is positional, because I've positioned it in such a way for that I can shoot the video. So you can see it.
Okay. So that is one thing. Question of conflict is, I had this opportunity to speak with Dr. B.M. Hegde. He is always against these surgeries. So at what point you will decide that surgeries are very much important, even if there is going to be a triple vessel block?
Now, as anybody asked this question, very good question. I like it. Thank you.
Thank you.
Okay. Now, this is a very serious concern where people are going, listening to Hegde's talk, Ramasamy, Govindsamy, Kuppusamy talk, and getting confused. What they say is definitely it. So when will you want to treat anybody? This is not a cardiac question, it's a general question. When will you want to treat anybody?
Triple vessel disease with symptom?
No, this is not for deans and professors, for UGs and PGs. So when will you want to treat anybody? When first the choice of, there is a saying in medicine, patient has to earn the treatment. That means not spending. They have to earn the treatment. There was one patient in my general surgery days when he was a very bad smoker, smoking about 20 to 25 packs or cigarettes a day, and he came with claudication. What is claudication?
Intermittent pain.
Okay, how many smokers are there in the room? It's okay, there's nothing wrong. Boys smoke, girls also smoke. So how many people smoke?
I have never seen some of our faculty smoking. They are very good people. I don't know, very bad people or good people?
Good, sir. No, smoking, not smoking is very, very good. I don't endorse it at all. I get very angry when people say that I smoke. So I'm very clear on that. So this claudication pain is when you walk for a distance, okay, say the patient from here to there, he walks, he has pain. So he comes to the OPD and I say, boss, you need to fix your leg. You need to stop smoking. And he had gangrene in the second, third toe up to, so we advised him, you have to do a mid-foot amputation. You guys know what mid-foot is amputated? Only the 4 fingers will be chopped off. So when we told, it's 2 minutes. This is just one. So when I said that, he said, no, I'll die. I don't want to do this thing. He went off. Exactly 1 week down the lane, he came back, holding his leg in his hand, literally, like this. Please chop my leg off. I cannot take the pain. So patient earns the surgery. When you tell, they don't listen. So any patient, when you'll want to treat is when they ask you for treatment. You understand? So asking, and they have to earn the treatment. That is the reason why I'm telling is this question, Hegde's question of whether will you treat them? Obviously, yes, if they come with pain. So pain is an indication. I have pain. If I walk to the toilet, I have chest pain. If I walk to the toilet, I have breathlessness. Pain or breathlessness during daily work activities is an indication to operate. Patient is suffering. Okay? Okay? Thank you.
Thank you, sir.
Thank you, sir, for providing your precious perspective. We now request the chairpersons to felicitate the speaker.
Hey, நீ என்ன language பேசுற? நானும் first நின்று பார்த்துட்டு இருக்கேன். ஏதோ பேசு. I'm thinking there is a loop mode going on in the, what is that?
Okay.
What's your name, dude? Huh? Where are you from, huh? Huh?
Australia returned, sir.
Yeah, I understand. Yeah, you're right, yeah. Yeah, okay. See you, dude. Catch you.
We now request the speaker, Dr. Dheeraj sir, to felicitate the chairpersons.
But I have one key. Toyota, this, whose key is this? Unga key அது இல்லையா ஓ கார் கொடுக்குறேன்னு நினச்சிங்களா அது கம்பன் சார் தான் கொடுக்கணும் இப்போ யாருக்கு இப்போ கார் எடுத்துகிட்டு போயிட வேண்டியதான் போல இருக்கு நோபடிஸ் ஏதோ வெளியிருந்து வந்தவங்களா தான் இருக்கும் உன்னுடைய கீயா யுவர் டேட் ஓ எங்கே விட்டு போனார் இங்கே இருக்காரா அப்போ ஓ 4 நாளைக்கு முன்னாடி விட்டுட்டு போனதா எப்படி போனார் அப்புறம் காரில் ஓகே ரைட்
The first cry, the moment every parent awaits. Yet oh how the miracle can be mired as their rosy cheeks turn blue.
Yet a marvel at the magical moment minces miles through a million miracles.
In the duskiest of dawns, the glint from a timely scalpel shines through as a ray of hope, bringing haven to a heaving heart with meticulous expertise at the opportune moment.
With that in mind, let us tune into our topic, timing of surgery in congenital heart disease.
The session will be chaired by Dr. Murugan sir, consultant pediatrician of Sivavarshini Clinic, Dr. Prabhakaran sir, consultant pediatrician, and Professor Dr. Anita Nancy Ma, head of Department of Anatomy.
We now call upon Ms. Abhinaya to provide a preface on the speaker of the hour.
We are honored to have Dr. Richie Sharon Solomon Sir, MD Pediatrics, DCH, DM Pediatric Cardiology, and Assistant Professor of Pediatric Cardiology in Institute of Child Health, Chennai. Sir have excelled in pediatric and pediatric cardiology and received Dr. Sir A.L. Mudalia Gold Medal in 2012 from Tamil Nadu Dr. MGR Medical University from MD Pediatrics. Sir has also presented short-term neurodevelopmental outcomes after corrective surgery for congenital heart disease and Indian infants. Let's put our hands together and warmly welcome Dr. Richie Sharon Solomon Sir to the stage.
Good evening, everyone. Thank you for the kind introduction. At the outset, I would like to thank the organizers for having me and for Dean Sir for inviting me for this conference. So the topic for me is timing in congenital heart disease. Go to the next slide. So as you all know, congenital heart disease can be broadly classified into two major types. One is acyanotic congenital heart disease and another is cyanotic congenital heart disease. So under acyanotic congenital heart disease, you have three subtypes. One is left to right shunt lesions, then the obstructive lesions, and then the regurgitant lesions. The most common is the left right shunt lesion. In that you have ASD, VSD, PDA, and aortopulmonary window, and AV septal defect. Under obstructive lesion, you have pulmonary stenosis and aortic stenosis. Coming to cyanotic congenital heart disease, the two broad subcategories are basically those with significant pulmonary stenosis, those without pulmonary stenosis.
So coming to guidelines for operating a child with congenital heart disease, there are many guidelines available. Most of these guidelines were developed for patients in high-income countries. So guidelines for Indian children was actually deliberated in a national conference in Delhi in 2018, and they developed an expert consensus guideline. So whatever timeline I'm telling you today is basically derived from that consensus statement developed by Indian pediatric cardiologists and pediatric cardiac surgeons. So coming to the most common lesion, it is the atrial septal defect. Atrial septal defect usually is diagnosed by picking up incidental murmur in childhood. Okay, so ASD, there are various types of ASDs like ostium secundum, ostium primum, ASD, and sinus venosus ASD. Most of these ASD in children, they behave asymptomatically. They won't have much of symptoms. So when you have a child with asymptomatic ASD, usually it is amenable to closure with device. Some cases we might have to send for surgery. The ideal age for surgery is a preschool age group. Generally between 2 to 4 years, you can try to close the atrial septal defect. Very rarely in some infants, large ASDs can cause problem and they can be symptomatic. And in selected patients with symptomatic ASD, you might have to intervene at a less earlier age, probably less than 1 year of age. So whenever you have a symptomatic infant with ASD, always be careful. Try to rule out other associated lesions. Sometimes there might be some anomalous pulmonary venous drainage or associated AP window. I think this is the most important slide for you. So a broad classification is into acyanotic and cyanotic congenital heart disease. Under acyanotic, you have left-right shunt lesions. Most of the lesions which you see come under this group: ASD, VSD, PDA, AV canal defect, and aortopulmonary window, which is quite rare. Then you have the obstructive lesions, which is basically pulmonary stenosis, aortic stenosis, and coarctation of aorta. Regurgitant, congenital regurgitant lesions are quite rare. Very rarely you can have a congenital mitral regurgitation. Then under cyanotic congenital heart disease, you have so many nomenclatures, but basically for your understanding, it is subdivided into two major categories: cyanotic heart disease with increased pulmonary blood flow and cyanotic congenital heart disease with decreased pulmonary blood flow. So when we mean decreased pulmonary blood flow, there is significant pulmonary stenosis that is causing decreased flow into the lungs. Okay. So in an older patient, if suppose ASD is not diagnosed in childhood, then as the child or the patient grows into an adulthood, then sometimes these patients may not be operable. So what do you mean by inoperability is, over a period of time, this slow increased flow into the lungs will cause secondary capillary changes in the lung capillary bed, leading to elevated pulmonary vascular resistance. So beyond a particular point, you can't operate this patient. So in an adult, you should be very careful before you send them for device closure or intervention. So they have a cutoff known as pulmonary vascular resistance less than 3 Wood units. If it is less than 3, then you can safely send them for surgery or device closure. If it is more than 3, you should be very careful. So coming to ventricular septal defect, they actually constitute the major chunk of congenital heart disease, excluding bicuspid aortic valve. The clinical presentation of a VSD depends on the size of the VSD and the systemic and pulmonary vascular resistance. So what you should know basically in a VSD is there are many types. The spontaneous closure of VSD is very uncommon in large VSD. So if you are facing a large VSD in a small infant, it is quite unlikely to close. Inlet VSDs and malaligned VSDs, they are also unlikely to close. The most common VSDs that can close is muscular VSD. Muscular VSD chance of closure is more than 50% at 5 years of age and more than 80% by adolescence. So if you have a child with muscular VSD, probably you can counsel the parents that there is a higher chance of spontaneous closure. But if you have a very large VSD detected at birth, the possibility of this child going for surgery is much higher. Okay. So we basically categorize VSD into 3 types for convenience of management. So you can categorize it as small, moderate, or large VSD. So when do we say the child has a small VSD? So when there are no symptoms. and there's no dilatation of cardiac chamber. So for a VSD, which chamber would you expect to dilate? Large VSD, right side chamber or left side chamber? Can somebody answer? Large VSD, which side chamber will dilate? Left side chambers, okay? So when there is significant VSD, that you expect some dilatation in the left-sided chambers, left atrium and left ventricle will dilate. So when it's a small VSD, I don't expect any dilatation of the chambers. And PAH means pulmonary artery hypertension. That usually develops when there is increased flow into the lung capillary bed. So that happens when there is a large shunt. So usually it happens with moderate or large VSD. So in a small VSD, child is essentially normal. So most of these cases, we follow them up medically. We don't advise any intervention. Surgery or some intervention is advised in a small VSD only when the child develops an episode of infective endocarditis, or when there is a significant aortic cusp prolapse leading to aortic regurgitation, or a new onset right ventricular outflow tract obstruction. Some pulmonary stenosis develops in the infundibular region due to a small VSD. Only in those cases we advise surgery for small VSD. When you come to moderate VSD, when do we say it's moderate VSD? There is some dilatation of left-sided heart chambers. Pulmonary artery pressure is slightly elevated, more than normal, but not severely elevated. Then those cases we categorize them as moderate VSD. And if they are asymptomatic, we advise closure by 2 to 5 years of age. I'm not going to the details of how we are going to close it. The timeline alone I will tell. When the child has a moderate VSD and if they are symptomatic, they are basically controlled by medication, then you can advise closure by 1 to 2 years of age. So when do you say the child has a large VSD? When there is significant left-sided heart chamber dilatation, when the pulmonary artery pressure is equal to systemic pressure. That means the VSD is so large, LV pressure is transmitted to the RV chamber, that is directly transmitted to the pulmonary artery bed also. So at all three places, the pressures are same. So that means pulmonary artery pressure is equal to systemic arterial pressures. Those cases are categorized under large VSD. So these patients, because of increased flow through the lung, these children, these infants will present early in the infancy with breathlessness, feeding difficulty, failure to gain adequate weight, and they are prone for recurrent respiratory tract infections. So for those patients who have very poor growth, and when this congestive cardiac failure is not controlled by medication, we will have to advise surgery as soon as possible. Suppose you are able to put them on anti-failure drugs. What are the anti-failure drugs you can use? Diuretics like? What are the common diuretics that are used? Furosemide, spironolactone, enalapril. These drugs are the common drugs that are used to control heart failure. So if the heart failure is controlled with these medications, then probably you can wait up to 6 months for surgery in a large VSD. So coming to PDA, what is PDA? Patent ductus arteriosus. What is it? What does it connect? Aorta to pulmonary artery. So it's a normal structure in every newborn. Okay. So usually the PDA closes soon after birth. Probably a physiological closure by 24 hours, anatomical closure by 3 days. But there is a timeline for preterm infants. In preterm infants, spontaneous closure is common even up to 1 year of age. It ranges from 35 to 75%. In a term baby, probably it can close up to 3 months, small PDAs. But large PDAs generally don't close. So again here for management purpose, we categorize them into 3 categories: small PDA, moderate PDA, and large PDA. So when do we say it's small PDA? Again, the same principle which we use for VSD. So when there is no chamber dilatation, or when there is minimal LV volume overload, or when there is no pulmonary artery hypertension, when the child is absolutely normal, we categorize them as small PDA. For these children or infants, we can advise surgery by 1 to 1.5 years of age. When do we categorize them into moderate PDA? When there is subtle LV volume overload and when there is a slightly elevated pulmonary artery pressure, and there is no or mild CCF, you categorize them as moderate PDA. For these children, when there is no CCF, no congestive cardiac failure, you can close them by 6 months to 1 year. If there is CCF, you close it at an earlier age. So basic funda is, if they are symptomatic with cardiac failure, plan for an earlier closure. If they are asymptomatic, you can wait probably up to 1 year. So when do you say there is large PDA? When there is significant LV volume overload and there is significant pulmonary arterial hypertension because of the direct transmission, because it's a large PDA, there is no resistance to the blood flow. So whatever is the systemic arterial pressure, that is transmitted directly to the pulmonary artery and the pulmonary vascular bed. So there is severe PA. So in these patients, you will have to advise earlier closure. If there is significant CCF, as early as 3 months, you might have to close. So there is one more category known as silent PDA. When do we call it as a silent PDA? You don't have a clinically audible murmur, but when you do echo, you can see a flow through the ductus arteriosus. So these children will be completely asymptomatic, and as there is no clinically audible murmur, we generally don't advise closure. We can just follow them up medically. So here also in VSD PDA, sometimes there is a failure to diagnose these children in the childhood period. They might be picked up when they are in the adolescence or in the adulthood. Again, we have criteria for closure in these patients. I think I'll skip it. So then you have the next category of disease known as a AV septal defect. So AV septal defect, what are the components of AV septal defect? What defect is there? Is there a VSD? Is there a ASD? So it's actually a spectrum. So broadly, we can divide into partial AV septal defect and complete AV septal defect. In partial AV septal defect, there is only ASD. The type of ASD here is an ostium primum ASD. Under complete AV septal defect, you have a large ASD and a large VSD. Other than that, you might have some AV valve regurgitation on the left side. But for your understanding, let's keep it simple. Complete AVSD, there is a large VSD and a large ASD. Partial AV septal defect, there is a ASD and an intact ventricular septum. So when there is complete AV septal defect, if the heart failure is uncontrolled, try to close it as soon as possible. If the heart failure is controlled, probably surgery at around 3 months of age. Partial AV septal defect, usually there is no VSD. You can advise closure at a later age, probably around 2 to 3 years of age. But sometimes when they have significant AV valve regurgitation on the left side, you might have to advise earlier closure. There is one thing to remember here, AV septal defect, there are associated anomalies possible. Left ventricular outflow tract abnormalities can be there, and they can be associated with some syndromes. Most common association is with the Down syndrome. It's as high as 50%. So in Down syndrome, if the child has an associated complete AV septal defect, the development of pulmonary vascular disease, I told you, right? When there is a large shunt, this shunt actually affects the pulmonary capillary bed. And over a period of time, this PVR, I told you, pulmonary vascular resistance, it slowly increases. And in Down syndrome with a complete AV septal defect, this rises quite fast and it becomes irreversible very early. So when you have a Down syndrome with a complete AV septal defect, you have to advise surgery much earlier, as soon as possible, maybe even less than 6 months. So aorta pulmonary window, it's basically a communication between the aorta and the pulmonary artery at a much closer level to the annulus. These patients, if they have uncontrolled heart failure, advise surgery as soon as possible. If there is controlled heart failure, probably you can wait up to 3 months. Coming to coarctation of aorta. So here there is a narrowing in the part of aorta which is distal to the left subclavian artery, right? So this narrowing will cause a pressure gradient. So ideally, gold standard for measurement of coarctation gradient is transcatheter-wise hemodynamic assessment. So all these guidelines of 20 and all has come from those measurements, but we do use echo as a surrogate for invasive measurement. But again, the coarc gradient depends on the presence of a normal cardiac function, normal LV function, and presence of a normal cardiac output. Suppose if the LV function is affected, even if you get a low gradient, that might be significant. So isolated interpretation of the gradient should not be done. It should be taken only in the context of how the patient is behaving, what is his clinical status and hemodynamic status. So numbers alone doesn't decide surgery. So, but once you categorize it as severe coarctation, immediate intervention is needed whenever there is LV dysfunction. As the last speaker discussed with you, LV function, LV ejection fraction less than 55 or 50. When there is LV dysfunction, you advise early intervention. Or when there is a presence of congestive cardiac failure and presence of upper limb hypertension. Usually in coarctation, a newborn baby and probably young children, they might present with congestive cardiac failure. Older children and adolescents might present with isolated elevation of upper limb BP, okay? That's the way you pick them up. So you can wait for some time in coarctation when there is normal LV function and there is no evidence of congestive cardiac failure, and there is just an isolated upper limb hypertension. Probably even slightly more period you can wait when there is normal LV function, no CCF and no upper limb hypertension. But whenever there is a gradient more than 20, you will have to intervene. So coming to tetralogy of Fallot. So what is tetralogy of Fallot? Can somebody tell me the components of tetralogy of Fallot? Overriding of aorta, pulmonary stenosis, right ventricular hypertrophy and large VSD. So this is one of the most commonest cyanotic congenital heart disease of the entire list, okay? So tetralogy of Fallot, most of these neonates, when they present, are they cyanosed? Usually they are not cyanosed. Usually cyanosis is not much evident soon after birth, but by 6 months, more than half of these patients become cyanotic and become symptomatic. What is one important determinant of presence of tetralogy of Fallot? What symptom you can elicit? Cyanosis and cyanotic spell. You can get that history from the mother. So presence of a hypercyanotic spell is quite diagnostic of tetralogy of Fallot, and these spells are quite common between 2 months to 6 months of age. And probably as they grow older, if you don't intervene, some of these patients, they may not get cyanotic spells after 2 years of age. So when the child is stable with minimal cyanosis, you advise total repair at 6 to 12 months, around 1 year, right? Based on institutional preference as per the surgical outcomes. So what do? They close the VSD, they relieve the right ventricular outflow tract obstruction, and various levels of problems you can have. You can have a small main pulmonary artery, you can have a narrowing in the proximal branch pulmonary artery. Each is corrected during the surgical repair. So, but if they are symptomatic, if they have cyanotic spells at a much earlier age, less than a year, if they are very symptomatic, less than 6 months, you might have to do something, because each cyanotic spell can lead to death of a baby. So if the baby is less than 6 months having recurrent cyanotic spell, it's better to do a palliative procedure rather than a definitive complete procedure, because the outcomes of a palliative procedure is better than a complete repair at an earlier age. So what are the palliative procedures you can do in these children? So the basic problem is, why do they get cyanotic spell? There is a decreased blood flow into the pulmonary artery, right? So you will have to do some surgery to increase the pulmonary blood flow into the pulmonary artery. So you can use the shunt you can make a connection between the systemic artery to the pulmonary artery. We call it by a name called BT shunt, okay? So previously they were doing classic BT shunt, nowadays we do modified BT shunt, where we use a Gore-Tex tube to connect the systemic artery. Usually the left subclavian or right subclavian artery is connected to the pulmonary artery. This procedure is known as a BT shunt. So we can do a palliative procedure to augment the pulmonary blood flow and relieve the baby of the cyanotic spell. After some time, as the baby grows, then you can plan a definitive procedure. There is one variant in TOF. Sometimes an anomalous coronary artery, a left anterior descending artery, might cross the right ventricular outflow tract. If that happens in presence of a hypoplastic pulmonary artery annulus, that means hypoplastic, very small P annulus, you might have to augment it. That means you have to increase the size of the P annulus by cutting it open. So that cannot be done when there is a coronary artery crossing that area. In those cases, we might have to put an additional tube from connecting RV to pulmonary artery. It's an RV to PA conduit. So you try to increase the outflow from the right ventricle to pulmonary artery using a conduit. So that is generally done more than 10 kg child. You can do a VSD closure with RV to PA conduit. Suppose if there is significant cyanosis and child is going for spell, the child is having this problem of abnormal coronary artery, then probably you can do a palliative procedure early if the child is less than 10 kg and follow it up with a definitive procedure later. There is one variant known as a TOF with absent pulmonary valve. This is a rare variant in TOF. Usually the main problem here is a incompetent pulmonary valve. So that leads to development of pulmonary stenosis and pulmonary regurgitation. It usually starts from the fetal life, and this leads to a slightly different thing. This leads to a dilated main pulmonary artery and dilated branch pulmonary artery. So the main presentation here will be, there may be cyanosis, but babies have significant respiratory distress. It can range from stridor to significant respiratory compromise, which might require mechanical ventilation, and they can develop recurrent respiratory tract infection, which is quite unlike in TOF. In pure TOF, you don't have recurrent respiratory tract infection. They can have hypercyanotic spells, but not recurrent respiratory tract infection. But in a TOF child, if they have breathlessness and recurrent respiratory tract infection, probably you are dealing with this variant. So in these children, if they have very significant symptoms, you might have to intervene early at 4 to 6 months. If they are asymptomatic, probably you can wait till a year and then do the complete repair, close the VSD, put in a new valve, then also augment the dilated branch pulmonary arteries and the main pulmonary arteries. VSD with pulmonary atresia, this is one extreme form of TOF. So here there is absolutely no communication between the right ventricle and the pulmonary artery. So there are various types here. I'll simplify it for you. First type is actually, there is a main pulmonary artery there seen, right? That is connected to right and left branch pulmonary arteries. There is only valvular atresia. So that's a short segment pulmonary atresia. You call it as a short segment pulmonary atresia. So there is no antegrade flow from the right ventricle to pulmonary artery. So how is the branch pulmonary artery supplied? It's supplied through ductus arteriosus. So in these cases, if there is significant cyanosis, plan a BT shunt early. If there is no cyanosis, I mean, if there will be cyanosis, you can't avoid it, but if there is not much of spells, if there is adequate blood flow into the lungs, then you do total correction at around 1 year of age. The second type, here there is absolutely no main pulmonary artery, absence of main pulmonary artery, and the duct is the one supplying the branch pulmonary arteries, and branch pulmonary arteries are of good size. Here again it's the same thing, very early presentation, you do some surgery to augment the pulmonary blood flow. When PDA is not sufficient, you do a BT shunt. That increases the pulmonary blood flow. By some time, definitive surgery at a later age. Third type is here you have a confluent branch pulmonary arteries, but it is additional aortopulmonary collaterals from the descending thoracic aorta, which is supplying the lung, that is a major part. Principle here also is the same. Earlier age of presentation, do a palliative procedure. Definitive procedures is slightly more complex than the other two subsets because there is major aortopulmonary collaterals which has to be addressed. I will not go into the details of it. They call it as a unifocalization and all. So those surgeries are done at a slightly later age. So this is the worst type to have. The branch pulmonary arteries are not confluent. Both the lungs are supplied by major aortopulmonary collaterals. This is a very tough thing to address even surgically. So coming to TGA, I think this you should know. What is TGA? Transposition of great arteries. What happens? Normally LV is connected to which great artery? Aorta. So in transposition of great arteries, it is the opposite thing. So LV is connected to pulmonary artery, right ventricle is connected to aorta. So there will be significant cyanosis and all these babies will be presenting much early. It's a quite dangerous disease. You'll have to address it early. So the basic thing is when there is just a transposition of great arteries with probably a small V, ASD and a PDA, we call it as a simple TGA. When there is associated VSD with other associated cardiac anomalies, we call it as a complex TGA. For a simple TGA, when do you want to operate? Most babies are symptomatic at birth. So what do you think is ideal age for surgery? You have to do it very early, okay? Any time after 7 days to 3 weeks is the ideal time for surgery. So surgery will be a replacement of the great arteries. So you take the aorta from the right side, anastomosis to the left side of the heart, take the pulmonary artery from the left side and anastomosis to the right side of the heart. So it's known as arterial switch operation. You're switching the great arteries. So ideal age for we call it as a TGA with intact ventricular septum. So that means there is no VSD. So ideal age for arterial switch operation is around 7 days to 3 weeks. So suppose if you pick them up late, some babies are discharged even before the diagnosis of TGA is made. Sometimes they fail to do the forelimb saturation, and they fail to check the pulse oximetry, they fail to diagnose the tachypnea. They might present as 1 month or 2 months. Those cases management is slightly more tricky because the LV normally is much thicker compared to the right ventricle after 6 months, right? Initially you might have a RV which is hypertrophied because of fetal circulation. As the baby grows, LV slowly hypertrophies and hyperplasia is established because of the higher systemic vascular resistance, right? So in these cases, LV is connected to pulmonary artery. So what happens if they are undiagnosed? Very soon this LV will start to regress. That means the LV wall thickness will decrease. So in those cases, doing an arterial switch operation is difficult unless this LV is trained to handle a systemic arterial pressure after surgery. So that is the two-stage switch. You don't have to understand much in it. Remember one thing, they try to tighten up the pulmonary artery first, then they do the arterial switch operation, basically to train the LV to handle the higher systemic afterload after the arterial switch operation. If that is risky, some centers, if they're present at 1 year and all, very rarely you can have a case presenting at 1 year with TGA intact septum. They just do the atrial switch. They just try to direct the pulmonary venous blood into the right atrium, into the right ventricle, and then into the aorta. And the systemic venous blood is directed into the left ventricle, into the pulmonary artery, right? So then you have a subset known as TGA with VSD. Here you can have slightly longer time for surgery, probably at around 6 weeks of age to 3 months you can operate these patients. Coming to DRV, that basic understanding you should know is both the great arteries are connected to right-sided ventricle, okay? There are various types of presentation. They can present with cyanosis or without cyanosis. So based on that, you have various types. If they present with cyanosis, that's known as TOF-like. If they present without cyanosis, they are taken as VSD-like. If they have cyanosis with heart failure, we take it as TGA-like. I won't go into the details of this. So here again, the basic concept is significant cyanosis, do some palliative procedure early. For your understanding, I'll tell it as a systemic to pulmonary artery shunt, probably a BT shunt. Wait for some time, then decide on the definitive procedure. So univentricular heart, I'll try to simplify it. Basically, normally there are two ventricles. One ventricle handles the pulmonary circulation, another ventricle handles the systemic circulation. So when do we call it as a univentricular heart? When there is only one ventricle, or there is one ventricle and the second ventricle is rudimentary without an inlet portion. That means it's too small to handle, right? So in these cases, there are various types, okay, various nomenclatures. Basically, for your understanding, one group has increased pulmonary blood flow, another group has decreased pulmonary blood flow. Our management is based on that. So how do we manage these patients? Based on the age of presentation and whether there is pulmonary stenosis or there is no pulmonary stenosis, right? So various surgeries are there to address this. So when there is increased pulmonary blood flow, we do this first procedure. It's known as PA banding. So that means there is a lot of flow into the lungs. We try to put a tightened band around this main pulmonary artery, try to decrease the pulmonary blood flow. The next surgery is systemic artery to pulmonary artery shunt. I was telling you all along, right? There are many types like classic BT shunt, modified BT shunt. This surgery is basically to augment the pulmonary artery blood flow. So you connect a part of the systemic artery to the pulmonary artery to increase the flow. So this is basically done in which category? Cyanotic heart disease with decreased pulmonary blood flow. Whereas the first surgery is done in cyanotic heart disease with increased pulmonary blood flow. That is a major difference. Then all these categories of patients, both the cyanotic heart diseases with increased pulmonary blood flow and cyanotic heart disease with decreased pulmonary blood flow goes to the next stage surgery, which is known as Glenn. Just remember what it is. Glenn surgery connects the superior vena cava to the pulmonary artery. It can be on the right side or the left side. The final surgery done in all these univentricular heart patients is the Fontan. Fontan, what do you do? You connect the IVC also to pulmonary artery. So basically, the funda is, what is happening is you have only one ventricle to handle it. And you want that ventricle to handle the systemic circulation because systemic circulation is more important. The pulmonary circulation, you try to take it out of the heart in stages and put it directly into the lung. So initially, for a baby, the flow from the SVC is much higher compared to IVC. So you take the SVC and connect it to the pulmonary artery. As the child grows, then maybe around 4 to 5 years of age, you connect the IVC also into the pulmonary artery. So that means entire venous blood is not going into the heart, but it's going directly to the lung. So you are completely offloaded the heart of the venous circulation. So what goes into the heart is the oxygenated blood through the pulmonary veins, and the one developed ventricle, which is good, that handles the systemic circulation. So this is what happens in univentricular hearts. So I told you, right, and there is no PS in univentricular heart. First surgery will be a PA banding to decrease the pulmonary artery blood flow. Next will be the Glenn, followed by Fontan at around 5 years. When there is pulmonary stenosis, first surgery will be to augment the pulmonary blood flow. So you do some systemic to pulmonary artery shunt. Most common thing done is a BT shunt. then glension around 6 months, then later Fontan. So Fontan surgery will be the final surgery for any univentricular heart patient. So when there is balanced circulation, that means not much of cyanosis, you wait for the saturation to fall. When it falls, do a shunt as per the age. Earlier age, you do a systemic artery to pulmonary artery shunt. Slightly older age, more than 6 months, do a glension. Again, the final surgery will be the Fontan. So truncus arteriosus, the coronary artery, pulmonary artery, systemic artery, all arise from a single great vessel from the heart, right? Everything is common origin. So you are able to see only single arterial trunk. So in these patients, when they present early with heart failure, do early surgery. Maybe if they are controlled, if symptomatic, maybe at a later age, maybe around 2 to 3 months, you can operate. So coming to TAPVC, what is TAPVC? Total anomalous pulmonary venous connection. That means the pulmonary venous blood is not entering the left atrium, but entering somewhere in the right atrium or through the IVs, hepatic veins into the right side of the heart. So none of the oxygenated blood is going to the left side of the heart. Only blood that is going to the left side of the heart is the shunt which happens across the ASD or a PFO. So if it is obstructed, most common type of TAPVC which can be obstructed is infracardiac TAPVC. It is actually one of the one and only emergency cardiac surgery you might have to do in a baby with congenital heart disease. So infracardiac TAPVC, highest chance of having an obstructed TAPVC, they need an emergency surgery. All other types of TAPVC, they may be symptomatic or asymptomatic, but definitely surgery should be done as soon as possible. I think I'll skip CCTGA. Epstein's anomaly of tricuspid valve, it is an abnormality of the tricuspid valve where the leaflets are adherent to the right-sided ventricle and the functional right ventricle becomes small. There are various guidelines when you should operate. So I think the take-home message is more important. Majority of shunts, always remember, has to be closed much early. Most of the surgeries are completed by 1 year of age, right? Then weight is not a criteria for surgery. You cannot deny surgery for a baby just because the baby has inadequate weight. The main reason here is obstructed TAPVC. Baby might be just 2 kg or 2.5 kg. Still you have to operate. TGA, presenting at 1 week, maybe 3 kg, you have to operate. Large VSD, child maybe 4 or 5 kg, but you might have to send it to a center which is capable of doing surgeries even though the weight is low, right? So weight is not a criteria to decide the timing of surgery. You can't ask a child with a large VSD to wait till the child gains 10 kg, then to operate. It will never gain that much of weight. Child will die before that. So plan surgery based on the presentation. Cyanotic child, one thing you should remember is when there is no pulmonary stenosis, always first surgery should be done early. First surgery is a PA banding, it has to be done early. If you fail to do that surgery less than 6 months or 1 year, then most likely these babies are going to be inoperable. No surgery can be offered in the future. But if there is pulmonary stenosis, parents have time to decide on the procedure because you have various surgeries that can be offered. But when there is no pulmonary stenosis, you should be very careful. Child will go for irreversible pulmonary vascular hypertension much early, and you may not be able to do anything in the future. Okay, thank you.
Thank you, Rishi, for your excellent lecture on timing. I think I have understood. Previously, we used to wait for the weight gain. I used to tell our Srimati madam, weight varla அப்படின்னுவாங்க. எப்படி மேடம் CCF இருக்கும்போது எப்படி weight வரும்? So ultimately, we have lost so many children.
I think that is a major change that has happened. Weight is never a criteria. Nowadays, some centers they say we have to gain weight, but it never happens. You will have to operate if the child is having bad symptoms.
Okay. Those days, we failed to diagnose many complex cyanotic disease. After few weeks, die. The parents used to blame. They have undergone sterilization also. I think what is the guideline available I think in other countries, American Academy of Pediatrics says SPOT at birth or at the time of discharge is a good screening procedure.
Still we advocate it, sir. Even in India, formalin saturation can pick up most of the critical congenital heart disease. Maybe some acyanotic heart disease like ASD, PDA, they
at
might
least
be missed.
cyanotic
But
heart disease you
yeah,
can
most
find
of the critical congenital heart diseases which have to be
Is it
addressed.
followed all over India or in DIC or in ICH at least? You do.
It is supposed to be followed, sir, but sometimes it's a sad thing. Staff nurses take the reading. It is not accurate. Baby is crying.
Government order, all.
I am not sure about that, sir, but it is there in the neonatal guidelines and pediatric guidelines. Folum saturation has to be done.
We are doing in our hospital. I hope so. Okay. So we have very limited number of.
It is one of the easiest way to pick up congenital heart disease, even when there is no option of echocardiography.
Okay, thank you.
Thank you, sir, for sharing your knowledge and experience. I'm having one doubt, sir. You have listed so many congenital heart diseases, sir. Can we be able to diagnose this in a ultrasound itself from before birth? Anomaly scan itself?
Anomaly scan, most of the congenital heart disease can be diagnosed, but certain lesions might be missed. That also we should remember. Anomalous pulmonary venous connection, TAPVC. It's a posthumous chamber. Sometimes it's technically difficult to view that anastomosis of the pulmonary veins into the left atrium. It might be missed. Outflow tract obstructive lesions. Sometimes, in utero, it's more of the pulmonary flow through the pulmonary artery, right? So only less amount of blood flow passes through the ductus and into the descending aorta. You might miss a coarctation or severe hypoplasia of the aortic arch. Other than that, in a good center where they have experience with fetal echoes, they'll be able to pick up majority of the major congenital heart diseases.
Thank you, sir, for furthering the first steps, and thank you to the chairpersons for your keen expertise. We now request the chairpersons to felicitate the speaker.
Now we request the speaker, Dr. Rishi sir, to felicitate the chairpersons.
The prologue may have ended, but the journey continues. As these eminent minds today have passed on the torch of knowledge, we bear it in our minds to enrich it as we leap forward.
Thank you, speakers, for your treasured time, and dignitaries for your august presence. And tons of gratitude to the organizing committee, without whom this event wouldn't have been a great success. And kudos to the people behind the screens for their invaluable efforts. And last but not the least, the audience for your presence, patience, and participation in this conference. Once again, thank you all and have an energetic evening.
என்னம்மா அதுக்குள்ள அவார்ட்லாம் கொடுக்கணுமா அந்த அதுக்குள்ள தேங்க்யூ ஆல் சொல்லிட்டேன் கூப்பிடு ரெப்புங்களை கூப்பிடுப்பா.
We now invite all the student representatives onto the dais.
Kunda. Dr. Richie Solomon is my colleague, Dr. Solomon's son. அவரும் பயங்கர இன்டெலிஜென்ட்டு இவனும் இன்டெலிஜென்ட்டாக இருக்கிறான். Okay. So he is both Dr. Solomon and myself was working in ICH, and he retired and joined Balaji Medical College, and from there also he retired. So before that, I once again thank all the organizing committee members. They have toiled for many months. Although it may look very simple to you, they have toiled, especially Dr. Anjugam, the organizing secretary team led by Dr. Kupuraj, Anjugam, Pavalavali, and so many other people, and all the volunteers, student representatives. I must thank the dancing team. எப்போ சொன்னாலும் உடனே ஒரு பிரமாதமாக ஒரு டான்ஸ் ஆடுறாங்க. எனக்கு ரொம்ப அந்த ரீல்ஸ் போடுறதுக்கு ரொம்ப சந்தோஷமாக இருக்கும், டகா டகான்னு போடுறதுக்கு. ஓகே, அந்த இது ஆமாம் வாமா. ஸோ ஐ தேங்க் audiovisual team, Govindaraj and Vimaloda Chittappa, Siva, okay, all the other team. And also delegates came from our Tiruvannamalai district, our IAP team, Dr. Murugan, Dr. Tamilmani, Dr. Satish Kumar, Dr. Rajashekhar, and Dr. Karnanidhi, Dr. Prabhakar, and so many other people. இவங்களெல்லாம் நானே ஆர்டர் பண்ணி வரவழைக்கிறது, அவங்ககிட்டலாம் சொல்கிறது இல்லை. ஸோ ஐ தேங்க் ஆல் தி ஸ்பீக்கர்ஸ். Within short notice, they accepted our invitation. Okay. So once again, thank you. We'll kuduma ellarum ivar rep vaangappa vaanguma quick vaanga kadadan pondama sir vaanga sir இத ஆஃப் பண்ணுப்பா அந்த போட்டோ தெரிய வர மாட்டேங்குது. ஓ வாப்பா எங்க பாக்குற நீ வாமா. ஆர்கனைசிங் டீம்ல இருங்க, குரூப் போட்டோ எடுக்கணும். வா வா வா, அடுத்தல வாமா. இது அப்படியே நீங்க வா. இப்போ ஆர்கனைசிங் கமிட்டி ரெப்ரஸன்டேட்டிவ் வாலண்டியர்ஸ் எல்லாம் வாங்க ப்ளீஸ், ஒரு குரூப்.
We request all the people from the dance group to join the group photo.
Evening dress code, only t-shirt, okay? No shirt, nothing. You want only t-shirt. Oh, only t-shirt.